Hello, welcome back. Myself, Dr. Roja, with specialty in psychiatric nursing. For those who have already subscribed me, might know me well. If you haven't subscribed, please do subscribe and share, as this channel shares lot of information related to nursing and medical and health related topics. Shall we all straight away move into the topic? Today we are going to discuss about mood disorders part 2. Last video I have released regarding mood disorders, and in under mood disorders we have discussed about mania. In this video we are going to discuss in detail regarding depression. Shall we start? Yes. Okay. Depression is a condition which usually depicts with low sad mood, and this term depression is very well known to everyone, and because most of us in our lives at some point would have been of low mood, sadness. So depression, before I could go in detail regarding this topic, I would like to say, among the mental health disorders, depression takes the major portion of the mental disorders. And it is predicted that it would be the second leading cause among the psychiatric disorders. Depression would be the second cause. So we need to understand in detail regarding depression, and I will proceed with this. According to American Psychological Association, depression is a common and a serious medical illness. You just have to understand this one: serious medical illness, mental illness that negatively affects the way we feel, the way we think, how we act. As depression causes feelings of sadness, loss of interest in daily activities once we have enjoyed, and we don't find any pleasure in that. So coming to depression, lifetime risk for common depression is 8 to 12% in males and 20 to 36. You can see this, almost it is nearly 30%. 20 to 26% of males, that means per 100 we can find common depression. Among females, 25 to almost 30 females, 20 to 35. That means it is very common among females when compared to that of males. And during one's lifetime, risk for landing up into depressive episode is about 8%. Next, coming to classification of depression. If you would have seen my previous class, you remember how we have classified mania, isn't it? So according to ICD, depression comes under chapter F, 32. Under 32, we have depressive episode, mild depression, we said moderate depression, severe depressive episode, and depressive episode with psychotic symptoms and without psychotic symptoms. Now, when depression is severe, we say, like, there are chances for person having psychotic symptoms. So whenever we say psychotic symptoms, presence of hallucinations, delusions, along with depression. Then we have atypical depression, depressive episode which is unspecified, where the cause is not known, and recurrent depressive episode, when an episode of depression is followed by another episode, we say recurrent depressive episode. Coming to etiological factors of depression. We are going to go a little bit in detail regarding these etiological factors of depression. Under that, first we'll see biological factors. Coming to biological factors, we neurobiological changes. When we say neurobiological, we have different types of neurotransmitters like serotonin, gabapentin, then adrenaline, noradrenaline, etc., etc. Acetylcholine. So, according to neurobiological researchers, they suggested that depression may be caused due to deficiency of neurotransmitters like serotonin, cortisol, and apart from that, we have imbalance in neurotransmitters which has been identified especially in MDD. When we say MDD, it is nothing but major depressive disorder. Please remember this, major depressive disorder. Then for this MDD, usually according to this research which was done by neurobiological researchers, they suggested that SSRIs, when we say SSRI is nothing but selective serotonin reuptake inhibitors. So reuptake inhibitors, when we give, it naturally increases the levels of serotonin, and apart from that, antidepressant drugs. Now, apart from deficiency of serotonin, we have decreased level of norepinephrine levels. Dysregulation of acetylcholine, which is a neurotransmitter. Then GABA. When we say GABA, it is nothing but it is a neurotransmitter. We say it as gamma aminobutyric acid. We say it as gamma aminobutyric acid. So, neurotransmitters, we have seen alteration in norepinephrine, dysregulation in acetylcholine, then changes in gabapentin, then we see like other changes in decreased levels of serotonin. Now, coming to genetic theories. First degree is relatives, it is increased chances of acquiring. Then monozygotic twins, 70% chances. Then we have circadian rhythms. I think you would have had an idea what are circadian rhythms. These rhythms are naturally programmed in our body. For example, we say age of attaining menarche, menopausal stage, menstrual cycles, sleep-wake cycles. Then hormonal secretions like early morning by 3 a.m. or hormones will start releasing, and by during daytime they increase, and by nighttime they decrease, and at nighttime we have melatonin which is secreted. So these are like circadian rhythms. If there are any alterations in sleep-wake cycles, hormonal secretions, arousal and activity patterns which are caused due to any medications or nutritional deficiencies, physical illnesses or psychological illnesses, they can also force a person to land up into depression. Then we have endocrine theories. This is very important for us to understand HPA axis. When we say HPA, it is hypothalamus, pituitary, adrenaline gland axis. Hypothalamus, pituitary, and adrenaline gland axis. So what happens in this? When a person faces stress, discomfort from the environment or within himself, see, from the environment, triggering factors or stressors which cause stress in a person, or stress which is faced, which comes within the individual. So once this stress is created in an individual, definitely some changes occur. What are those changes? So these changes are like hypothalamus receives these, and this hypothalamus triggers the pituitary gland to release CRF and AVP. What is CRF? So CRF is corticotrophin releasing factor. CRF is corticotrophin releasing factor. Then AVP. AVP means arginine vasopressin. As the hypothalamus stimulates pituitary gland releases adenocorticotrophic hormone, which has an effect on adrenal gland. What happens to adrenal gland? You know, adrenal gland consists of adrenal medulla and adrenal cortex. Now, adrenal medulla releases what? Adrenaline and non-adrenaline. So in adrenal medulla, usually it is mainly related to adrenergic system, which releases adrenaline and noradrenaline. Whenever adrenaline is released in our body, you know what happens: increased heart rate, perspiration, sweating, tension, and these catecholamines, they bring about change in our body. The way we think, when you're anxious, when you're in tension, you will not be able to think properly. You cannot remember things. These changes are. Next, coming to adrenal cortex. Adrenal cortex will also be triggered to release corticosteroids like glucocorticoids, mineralocorticoids, and we have effect on estrogens, testosterones. All these are secreted from the adrenal cortex. So apart from that, we have vasopressin, which is released. What is meant by vasopressin? It is otherwise also called as an anti-diuretic hormone, which is present in our body, which tries to maintain osmolar regularity in our body. It retains fluid balance. So vasopressin usually get activated when a person is dehydrated to maintain the fluid and electrolyte balance in our body. Now you just see the cycle, how it is happening. Hypothalamus stress from within or from environment triggers hypothalamus indirectly triggers pituitary gland releases this adrenocorticotrophic hormone, which will stimulate the adrenal gland, and adrenal gland will stimulate the adrenergic system as well as adrenal cortex, where glucocorticoids, mineralocorticoids are released, and indirectly they have an effect on kidneys and our BMR rate at that present or at that time also, if it is flight or fight mode, will be increased. So long term, if this cycle is being repeated daily, then we'll land up into a condition where all our major systems are affected. So you just see in this figure increased risk for cognitive behavioral dysfunctions like major depressive disorder, anxiety disorder, and memory problems. Then we have other cardiovascular conditions, increased risk for cardiac hypertrophy, hypertension, vascular damages. Immune system is affected, where increased risk for autoimmune syndromes, increased levels of cytokinins, then some inflammation, low grade or chronic inflammation, where we have back pain, arthritis, etc. If this is triggered and if it is continued for a prolonged period, a person can land up into diabetes, cancer, Cushing syndrome, obesity. So it's not just a topic on exam point of view, it is also with our personal lives too. We need to understand whenever we face stress, when we take it too serious, then how our body is affected. So whenever we face some stress, it is better that we do some meditation and use some recreational therapies and do some relaxation techniques. I hope you understood this endocrine theories. Next, because of this changes in brain anatomy, loss of neurons, you just remember these major areas like cerebellum, occipital lobe, parietal lobe, frontal lobe, cingulate, gyrus, and temporal lobe. We'll go in little bit detail later. Coming to psychosocial theories, psychoanalytic theory, or uh, like apart from psychoanalytic theory, like Sigmund Freud, you already know that it is given by Sigmund Freud. He explained in psychosexual theory 5 stages. If you go into personality development subject and if you just see psychosexual development, we call this as psychoanalytic theory also, which is given by Sigmund Freud. The first phase is oral phase. In this oral phase, loss of loved object, maybe the mother who is the primary caregiver, makes a person to fix at this oral stage, which is sadistic phase. During their infancy, if the caregiver is constantly being changed, person doesn't develop trust. And during their childhood, infancy period, if the loss of the loved object, it might be caregiver or the mother, can lead a person to depression. Coming to behavioral therapy, conditioned by repeated losses. It's not one event, maybe loss of job, maybe loss of loved one, maybe loss of valued objects or a property, conditioned, repeated losses which occurs at a frequent interval. So, person, if he faces one loss, maybe he tries to recover, but by the time he recovers, he lands up into with another loss and another loss, more chances of them landing up into depression. Next, coming to cognitive theory. Cognitive theory has something to do with our mind, the way we think. So, according to cognitive theory, if a person has negative expectation of self, negative expectations of the environment, and negative expectations of the future, negative thoughts constantly, if negative thoughts keep repeating in a mind, definitely person will have low mood. When we say negative expectations of self, I cannot do this, I cannot achieve, my life is a failure. Negative expectations from the environment, nobody bothers me, nobody loves me, nobody cares for me. Negative expectations of future, I cannot achieve anything in my life. I don't see anything better for my life. So these negative thoughts, if these thoughts are repeated again and again, definitely the person's life will be miserable. He will go into depression. Now, according to social theory, stressful life events like marriage, death, disease, financial loss, divorce, unemployment, there are numerous factors, stressful events do pose a person to land up into depression. Now, according to transaction model of stress, I want you to understand depression has multiple etiological factors. That's the reason I'm trying to explain to you in detail. According to transaction model of stress, internal and external demands, stressors. We said external might be from the environment. When we say internal, negative self-talks. So the stressor is within us. So when we appraise the two ways, primary appraisal and secondary appraisal. Coming to the secondary appraisal first, coping resources. Okay, primary appraisal, we have coping resources. That means whenever we face any problem or any stressor, coping resources are in two ways. Personal attributes. When we say personal attributes, it's about your personality or my personality. How do I face that problem? If I am self-confident, if I have a good self-concept, then I can face that problem. Stable environmental attributes. If I have a good support, good environment, supportive environment, maybe I will try to use it to fight with that stressor. Then coping responses, two ways of coping responses. When you face a problem, either you use emotional focused coping or problem focused coping. Problem focused coping means you directly attack the problem. You try to solve that problem. Emotional focused coping is you try to stabilize yourself, stay strong for yourself in your mindset. So you tell for yourself, I am going to face this, and you try to focus it emotionally. Coming to short-term outcomes, relaxation, and you increase your mood. Long-term outcomes will be physical health, mental health, and life satisfaction. When you try to cope up with these stresses in a normal way. But if you fail to cope up with these stressors, then we'll end up into depression. That's what transaction model of stress is. Next, coming to different types of depression, before we could go, I think you have understood regarding various etiological factors. Types of depression. We have two types of depression. Unipolar depression is one, that is unipolar, and the next one is bipolar affective disorder. Under this we have MDD. Already I said maniac depressive disorder. So unipolar depression is seen in 80% of the depression cases. If we take depression as 100%, 80% cases are unipolar depression and 20% of them are MDD or bipolar affective disorders. Under unipolar, we have two types, reactive depression and endogenous depression. When we say reactive depression, we said unipolar is 80%. If you take unipolar as 100%, 75% is reactive depression and endogenous depression is 25%. Reactive depression means like a depression which is characterized by disproportionate feelings of sadness, grief, anxiety as a result of stressful life events, loss of loved one, unemployment, physical illness, social problems, etc., etc. So you react to something external. External stressors. Stressors are multiple. This is called as reactive depression. Now, when we say endogenous, endo means within us. Endogenous depression, it is that these traits are present in us. It's a negative way of perception of life and familiar pattern of thinking. It comes as we grow. It is within us. And the cause is here in us. So reactive depression, we can treat it with antidepressants and person can recover. But when we come to endogenous depression, along with antidepressants, ECTs are given. So next, coming to bipolar affective disorder, maniac depressive disorder. Here, about 20% of the cases, what we have said, when we say it is a cyclic, person lands up in depressive episode for 2 to 3 months or 6 months or whatever it is, that episode when it is treated with antidepressants and ECT, next episode might be mania. And later on treated, the other episode might be depression. This is usually seen in bipolar affective disorders. Previously one slide we have seen about the areas where loss of neuron occurs. So major areas of depression, if we just see prefrontal cortex, right hemisphere, thalamus, left hemisphere, hippocampus, amygdala, and basal ganglia. These areas, what happens? Loss of neuron occur, and this I can explain to you in pathophysiology of depression. But remember that these areas of brain are affected because of loss of neurons. Coming to pathophysiology of depression, we have the first one, neurotropic hypothesis. When we say neurotropic hypothesis, neurons, neurotransmitters, you have to get that concept. We will see we have neurotropic hypothesis and monoamine hypothesis. Now, according to neurotropic hypothesis, it assumes that it believes that depression appears to be associated with a drop in brain derived neurotropic factor, BDNF. What is this drop in brain derived neurotropic factor? BDNF is present in our brain. It serves as a neurotransmitter modulator. It stimulates the neurotransmitter modulators. That means it increases the neuronal activity. It stimulates the neurons, neurotransmitters, levels especially in CSF and serum. If there is a drop or decreased, what happens? Neuronal activity will reduce. So they have done animal studies and human studies which indicated that stress and pain are associated with a drop in brain-derived neurotropic factor. So loss of this neurotropic supports contribution for atropic changes which occur in the brain, especially hippocampus and the areas where I have mentioned previously. I hope you got it. Whenever we face stress or pain, what happens? This has an influence on BDNF, and BDNF, I said, it is a neurotransmitter modulator. It regulates the neurotransmitters. So it brings about alteration in neurotransmitters, which brings about atropic structural changes in the brain, especially the parts which I have mentioned, hippocampus, frontal cortex, then cerebral hemispheres, etc. Next, coming to monoamine hypothesis. According to monoamine hypothesis, they believe that it has an clinical effect which is brought about by various drugs that cause some changes in neurotransmitters. So monoamine is an inhibitory neurotransmitter. A person, when he uses certain drugs, it is an inhibitor transmitter which indirectly affects the production of monoamine. And this monoamine, when it is decreased, okay, when there is a deficiency, definitely it affects the brain. So you just see the second part here, like monoamine hypothesis of depression suggests that it is related to deficiency in the amount or function of cortical, limbic system, serotonin, norepinephrine, and dopamine. So we have discussed about two hypotheses which we believe that the changes occur in brain due to changes in BDNF and monoamine. So here is a figure where when we are normal, what happens is a normal regulatory flow is there, but in depression, underactivities is noticed, especially in serotonin and norepinephrine. And when it is treated, these levels increase. Coming to symptoms of depression, we categorize it under emotional symptoms, thoughts, physical and behavioral. Emotions: sadness, anxiety, guilt, anger, mood swings, irritability. Now, depressed person usually does not get angry with other persons most of the times. With whom are they angry? They are angry with themselves, that they are not able to do anything, that they are incapable, they cannot tackle the things. So sadness, anxiety, guilty, anger, mood swings and irritability. Coming to thoughts, negative thought pattern, self-criticism, okay, impaired memory, indecisiveness, confusion, thoughts of death and suicide. Physical symptoms: lack of energy, tiredness, sleeping too much or too little, weight gain because lack of motivation to do any activities, they sleep for hours together, sometimes in depression, weight gain or weight loss. Due to depression, some doesn't eat and some overeat. Loss of motivation and substance abuse. We commonly see this substance abuse in males. Like whenever they're discouraged, I cannot say males, but females also, whenever they're discouraged or depressed, they feel like taking or consuming some drinks or some pills. Coming to behavioral changes, we see withdrawal from others. They stay for themselves, stick for themselves, neglect of responsibilities, changes in personal appearance because they doesn't do grooming. Now, coming to psychotic features, we said depression without psychotic symptoms, depression with the psychotic symptoms. So, psychotic features are noticed or observed in a person suffering with depression with psychotic symptoms. Some persons have delusions and hallucinations, mood incongruent depressive themes like dysphoric mood. Now, nihilistic delusions. Delusion is defined as false, unshakable belief. When we say nihilistic delusion, a belief that a person is non-existent. Now, when a person is fully depressed, they say, I wish I could die, I wish I could die. And at a point they feel and they believe that I am no more. And I am no more. And they say that whenever, it's a common thing, like no, when we are really hurted a lot and someone comes and how are you? Then you will tell, I am no more alive because of this instant. So, nihilistic delusion is a belief of non-existence of some person or a thing. Delusions of guilt, blaming, maybe loss of job, loss of loved one, feelings of guilty. If I was there, I would have done something. Delusions of poverty, that the person does not possess. It's not, when we mention poverty, this word poverty doesn't say that regarding money, but poverty in self-esteem, delusions that they are incapable, helpless, delusions of control, that they are being controlled by others. These are certain types of psychotic features we find in a person who is suffering with the delusions, means depression with psychotic features. Now, coming to depressive ideation or cognition, is a negative self-talk, negative expectations from the environment, from self. There are three types of depressive ideas which we see: feelings of hopelessness, feelings of helplessness, feelings of worthlessness. Very common. No hope in future, no help is possible now, feelings of inadequacy and feelings of inferiority are present in these persons, especially cognitive. This is the thought pattern which is commonly present in all depressive conditions. And as a result, when we say negative feelings which lead a person, hopelessness, helplessness, worthlessness, there is no point in me surviving in this world. Ultimately, they would come to that conclusion. There is no point of me living in this world because future is hopeless, life is worthless, and they take this step of suicide or suicidal ideation. So whenever a person with depression, suffering with depression, expresses that life is worthless, then you have to definitely ask a person if they have any plans of suicidal ideation or if they have any suicide plan. And factors that increase the risk of suicide is presence of hopelessness, divorced, widowed person, unmarried person, age above 40 years, verbal or written suicide plans. If they say we have to take it serious, then early stages of depression, recovering of depression, period of at least 3 months from recovery, you should observe the person for these signs of suicide. Next, coming to other features, we see like difficulty in thinking and concentration, poor memory, menstrual and sexual disturbances. Sexual disturbances, we said like HPA axis, we said the adrenal cortex will be releasing estrogens and testosterones, androgens. So when these are disturbed, these hormones are low, lack of interest in sex. Vague physical complaints like fatigue, aching, discomfort, decreased libido, dependency, passiveness, and spontaneous crying. Now, according to DSM-4, somatic symptoms of depression, already we have seen, but I just want to say what DSM-4 says regarding depression. One of the following is present during most severe period of current episode. What is that? Loss of pleasure in all or almost all activities. This is called as anhedonia. Anhedonia. Not able to feel pleasure in activities, pleasurable activities. Lack of reactivity to pleasurable stimuli, does not feel. So anhedonia. Three of the following: a distinct quality of depressed mood characterized by profound despondency, despair, or morseness, like empty mood, vague feeling. Depression that is regularly worse in the morning, early morning awakening will be there usually, and psychomotor retardation is seen or agitation, weight loss, anorexia, inappropriate guilt. Next, coming to diagnosis of depression. We have psychological tests regarding mania. You remember I said young mania's rating scale. For depression, we have so many scales, but commonly used one is Beck Depression Inventory and Hamilton rating scales. Then we do dexamethasone suppression test. Can you think why dexamethasone suppression test is done? Yes. If you go back to HPA axis, we said adrenocorticotropic hormone is released, which triggers adrenal gland, and adrenal cortex will release corticosteroids and mineralocorticoids. So when a person is in stress, steroid levels are high, cortisol levels are high. So when we do this dexamethasone suppression test, we can find out according to basing upon the levels of cortisol levels to what level they are suffering. Depression, mild, moderate, or severe. Next, toxicology screening suggesting drug-induced depression. We said monoamine hypothesis. We said some drugs do affect the neurotransmitters. So that's the reason we need to do toxicology, and based upon ICD-10 criteria also, we can diagnose the condition. Treatment for depression, somatic treatment. Antidepressants are given for these persons, and before we could prescribe this person with antidepressants, all whoever are administering these drugs, we should remember some basic points, that there are variety of classifications under the drugs which are prescribed for antidepressants, and at least to find out the effect of these drugs or efficacy of drugs, it at least takes 3 weeks. It's not that after administering a drug for a few days or maybe 5 days or 1 week, we cannot appreciate the response. So we need to continuously observe the person suffering with the suicidal ideation in depression. At least for 3 to 6 weeks, we need to observe these persons for the therapeutic response. And these drugs should never be stopped on own unless the doctor says it so. Coming to TCAs, I said antidepressants, there are so many classifications under that. First one is tricyclic antidepressants. We have bicyclic, monocyclic and all, but most commonly used nowadays are tricyclic, newer antidepressants. TCAs, we call them as TCAs. We can prescribe them with imipramine 75 to 150 milligrams up to 300 milligrams. And amitriptyline nowadays is not used due to dry mouth, blurry vision, and post hypertension. Newer antidepressants like SSRIs, we said decreased levels of serotonin will lead to depression, or it is found in depression. So we want to increase the level of serotonin. We are giving selective serotonin reuptake inhibitors. These drugs increase the levels of serotonin. So under this category, we have fluoxetine, sertraline, and citalopram. It's according to the doctor's choice and the condition of the patient they select. Then we have serotonin norepinephrine reuptake inhibitors, where these two are mixed, and these increases the levels of serotonin and epinephrine. We have venlafaxine and duloxetine and mirtazapine. Then MAO inhibitors. We said monoamine oxidase itself is an inhibitory neurotransmitters. Now, if these levels are decreased, like inhibitory neurotransmitters, if this inhibitory neurotransmitter level is increased in depression, we need to reduce that. So under this category, we have clotulin and maclobimide, and monoamine oxidase inhibitors B, we have another drug mentioned, salicylin. So these are certain drugs which are given under monoamine inhibitors. Dopaminergic degraded equally in both isoenzymes if they're prescribed. So the action of monoamine oxidase inhibitors, they inhibit the metabolism of biological amines and they elevate the mood of the person. Coming to this already said, they increase or elevate the mood of the depressed patient, and progress to mania. And if they are not carefully monitored, the person can land up into hypomania and mania. So we have to just monitor the person continuously, as said, from 3 weeks to 6 weeks. Next, coming to the other therapies, ECT. When we said ECT, in MDD, ECT is preferred. If it is a reactive depression, we said it can subside with antidepressants. But in cases where there is a suicidal risk, severe depression, stupor, psychomotor retardation, and treatment when it is not responding for antidepressants, and if there are presence of any psychotic features, we give ECTs. Usually 6 to 8 times ECTs are given, and given for 3 times a week. Maybe alternate days these ECTs are given. Then apart from that, some of the antipsychotics we have to be a little bit careful about is like risperidone, olanzapine, clonazepam, quetiapine, haloperidol, and these drugs are given, but you have to have a blood check whenever we administer, because agranulocytosis is caused by this as a side effect when we use these drugs. Then we have antidepressants, ECT, and other things is psychotherapies, psychosocial treatments, cognitive behavioral therapy, because we said negative self-thought, negative thought pattern. So we definitely need to change, bring about change in the thought pattern. Then interpersonal therapy mainly focus with how to communicate with other person, because these persons stay aloof for themselves. Social lack of social communication we see, so that's where interpersonal therapy comes. Then psychoanalytic psychotherapy, we said they get fixed at oral sadistic phase because of loss of loved one, and we want to find out, dig deeper into the root cause of the problem, and we can sort it out. Next, behavioral therapy, group therapy, and family and marital therapy. These family and marital therapies involved when we identify that there are any faulty family interactions which are existing, and if there are certain problems which are existing between the couples. So you choose these therapies according to the causes or factors which have triggered the person to land up into depression, or factors which are not precipitating factors. If there are any precipitating factors, we need to identify and use these therapies as per needed. So forms of depression, we said like bipolar, you already know, between mania and depression. But one thing, in my last mood disorders, I mentioned this word dysthymia. From euthymia to dysthymia, there is something midway called as dysthymia. Here, a person suffering with the dysthymia, he has low grade symptoms of depression that last for minimum of 2 years. That means these persons will go about with their activities of daily living, occupational functioning, fulfilling their responsibility, but they are not at all happy with their life. So the low grade of depressive symptoms, maybe mild, below mild, we can classify under dysthymia. So for this video, we'll stop till here now. And in our next video, we will see about bipolar disorders and nursing management on the whole. I hope you have understood. So far, we have discussed about depression, different types of depression, lifetime risk prevalences, and various etiological causes, how to diagnose depression, and what are the treatment modalities which we give for depression. Thank you all very much for listening to me, and I hope this video is very much useful, and it will help you for your education purpose. Please do subscribe and share with others. I will keep on sharing videos related to psychiatric subject as well as related to other nursing subjects. Thank you all very much. We shall meet soon. Bye.